The electrocardiogram, or ECG, is one of the most powerful and readily available diagnostic tools in modern medicine. This guide is designed to demystify the ECG, providing a clear, step-by-step method that anyone can follow. The goal is not to make you a cardiologist overnight, but to equip you with a reliable routine. By using a systematic approach every single time you look at an ECG, you will build confidence and ensure that you do not miss critical, life-threatening findings. This structured process transforms a confusing series of squiggles into a coherent story about the patient's heart, making you a safer and more effective clinician. An ECG is simply a recording of the heart's electrical activity as detected by electrodes placed on the surface of the skin. Think of it as listening to the heart's electrical symphony from different seats in a concert hall. Each electrode, or lead, provides a unique perspective. A standard 12-lead ECG gives us 12 different views, allowing for a comprehensive assessment of the cardiac conduction system. We use this invaluable tool for a wide range of common clinical presentations, including chest pain, palpitations or a fluttering sensation in the chest, unexplained fainting, syncope, shortness of breath, monitoring the effects of certain medications, investigating potential electrolyte imbalances that can profoundly affect cardiac function. The utility of the ECG extends far beyond just diagnosing a heart attack. It is a window into the heart's rhythm, its rate, and the health of its muscular walls. It can reveal evidence of an enlarged heart, inflammation of the sac surrounding the heart, pericarditis, or dangerous disturbances in the body's chemistry. For the emergency physician, the paramedic, the internist, or the nurse on the ward, the ability to quickly and accurately interpret an ECG is a fundamental skill. It often provides the first crucial clue that guides immediate management decisions, from activating a cardiac catheterization lab to administering life-saving medications. Before you can interpret the music, you must ensure the orchestra is set up correctly. In ECG terms, this means precise lead placement. Even small errors in where you place the electrodes can drastically alter the appearance of the tracing, potentially leading to a misdiagnosis. The standard 12-lead ECG uses 10 electrodes to generate 12 views. Limb lead, right arm, RA. Limb lead, left arm, LA. Limb lead, left leg, LL. Limb lead, right leg, RL, ground. Precordial lead V1, fourth intercostal, right sternal border. Precordial lead V2, fourth intercostal, left sternal border. Precordial lead V3, between V2 and V4. Precordial lead V4, fifth intercostal, midclavicular line. Precordial lead V5, fifth intercostal, anterior axillary line. Precordial lead V6, fifth intercostal, mid-axillary line. If an ECG looks bizarre, recheck lead placement. Once leads are on, confirm the machine's calibration. Look for the calibration box on the tracing. Standard gain, 10 mm per MV. Standard paper speed, 25 mm per S. Small square, or 0.04 S, 40 meters. Large 5 mm square, or 0.2 S, 200 meters. PR, 120, 200 meters. QRS, less than 120 meters. QTC, in 440 meters in men, 4/16 in women. Electrical axis, approximately minus 30 degrees to plus 90 degrees. A reliable system is your best defense against missing important findings. Following the same 10 steps, in the same order, every single time, trains your eyes and brain to be thorough. The first step is simple but crucial. Check the patient's details. Confirm the name, confirm the date, confirm the time. Verify calibration is set to 10 mm per MV. Verify paper speed is 25 mm per second. This prevents interpreting the wrong or misrecorded ECG. Step 2. Determine the rate. For regular rhythms, use the 300 method. Count the large boxes between consecutive R waves. Divide 300 by that number. Example, 4 large boxes, 300 divided by 4 equals 75 beats per minute. For irregular rhythms, count R waves in a 10-second strip. Multiply that count by 6. Step 3. Rhythm analysis. Is the rhythm regular or irregular? Are there P waves? Is there one P wave for every QRS complex? If yes, and P waves look normal, likely normal sinus rhythm. Once you have your 10-step system down, you can start to recognize specific patterns. Learning the key signature of common rhythms is a great place to start. Montage: atrial fibrillation, atrial flutter, supraventricular tachycardia, and ventricular tachycardia. Normal sinus rhythm is your baseline, a regular rhythm with an upright P wave preceding every single QRS complex. Atrial fibrillation, a very common arrhythmia, is identified by its classic irregularly irregular rhythm and the complete absence of discernible P waves. In contrast, atrial flutter often presents with a regular rhythm and characteristic sawtooth flutter waves, best seen in the inferior leads like lead 2, lead 3, and lead AVF. These distinct patterns are crucial to identify as they require very different management strategies. Supraventricular tachycardias, such as AV nodal reentrant tachycardia, are typically fast, regular, and have a narrow QRS complex, often with P waves buried or absent. This is a stark contrast to ventricular tachycardia, a life-threatening rhythm that is characterized by a wide complex tachycardia. A key sign that helps distinguish VT from other wide complex rhythms is AV dissociation, where the P waves march through the QRS complexes at their own independent, slower rate. At the most extreme end of the spectrum is ventricular fibrillation, which appears as chaotic, disorganized electrical activity with no discernible waves or complexes and, critically, no pulse. Beyond rhythms, there are high-yield diagnostic criteria for acute and chronic conditions that you must know. For a ST elevation myocardial infarction, the key is finding new ST segment elevation in at least 2 contiguous leads, often with reciprocal ST depression in opposing leads. For example, ST elevation in leads lead 2, lead 3, and lead AVF points to an inferior STEMI. Acute pericarditis can mimic a STEMI, but it typically causes diffuse, widespread ST elevation across many lead territories, often accompanied by PR segment depression, a highly specific sign. Other important patterns include those of structural heart disease. Left ventricular hypertrophy, or thickening of the left ventricle's wall, can be suggested by voltage criteria like the Sokolow-Lyon criteria. The S wave depth in V1 plus the R wave height in V5 or V6 is greater than or equal to 35 millimeters. Finally, bundle branch blocks are common conduction abnormalities. A right bundle branch block is identified by a wide QRS of at least 120 milliseconds and a classic RSR pattern, like rabbit ears in V1. A left bundle branch block also has a wide QRS but shows a broad, notched R wave in lateral leads like lead I and V6. Becoming proficient at reading ECGs is a journey of repetition and deliberate practice. To ensure accuracy, always start with the basics. Use calipers or the edge of a piece of paper. March out the RR intervals to confirm if a rhythm is truly regular. When measuring intervals like the PR or QRS, use the paper grid, count the number of small boxes, and multiply by 40 milliseconds. For a quick rate check, the 300 method is your friend. But for very fast or slow rates or irregular rhythms, counting the complexes on the rhythm strip and multiplying is more reliable. Be mindful that formulas like Bizet's for the QTC can be inaccurate at extreme heart rates. One of the most common sources of error is failing to recognize artifact, which can mimic serious pathology like ventricular tachycardia. Look for a march to T phenomenon in VT and check if the patient has a pulse. If the tracing is messy, check the electrode connections and ask the patient to lie still. Another major pitfall is failing to place the ECG in its proper clinical context. The ECG is a single piece of a much larger puzzle. An abnormal ECG in an asymptomatic, healthy young person means something very different from the same ECG in an elderly patient with chest pain. Treat the patient, not the ECG tracing. The single most impactful habit you can develop is to always compare the current ECG with a previous one if available. This simple act can instantly differentiate new, acute changes from chronic, stable abnormalities. What might look like a new ST elevation could be a persistent finding from an old aneurysm. What appears to be a new left bundle branch block might have been present for years. Make it a reflex to ask for and scrutinize any old tracings. Your path forward is clear. Practice, practice, practice. The must-know numbers are your foundation. PR 120 to 200 milliseconds. QRS less than 120 milliseconds. QTC less than 440 or 460 milliseconds, and a normal axis of -30 degrees to +90 degrees. Use the 300, 150, 175, 60, 50 sequence for quick rate checks. By consistently applying your 10-step system, you will build the skill and confidence to read any ECG in minutes.